Okay, so morning everyone. Welcome to our series on our new community health profiles, overviewing the health inequalities and health needs of our different community groups. Today we'll be focusing on the findings from our South African profile and discussing some of the health inequalities experienced by this group and what some of our next steps are. So I'm going to start the presentation by giving an overview of how we've defined the South African population within the profiles, some of the data that we've used, the limitations of this, and some of the demographic and geographical information. Then I'll discuss the key findings and specific inequalities identified with the profile. And finally, I'll talk about how the profiles can be used before we finish with a bit of a short Q&A. Before we start, just a bit of housekeeping. Sorry, just a message. Before we start, just a bit of housekeeping. Can you stay muted and turn any VPNs off during the webinar, just so it runs a bit more smoothly. But do feel free to put your hands up and unmute if you've got any questions. You can post any questions that you've got in the chat as well, and there should also be an anonymous Q&A section within the Menti. Slides will be uploaded to the Birmingham City Council website under the Community Health Profiles homepage, and a recording will be available on the Healthy Brum YouTube channel, and you'll be notified via email when the recording is available to watch. We're going to be using Menti during the webinar today, so that's just to get your feedback and provide some opportunity for interaction. So you're not just listening to me talk about inequalities for an hour. We'll just get everybody set up on that now. So we're going to be asking some questions where you might need a bit of time to think about or write out your answer. So can I just ask someone in the team to pop those questions in the chat now? The first Menti question is, what's one thing you're looking forward to learning or discussing in today's webinar? Just wait a minute or so for people to respond. Okay, so learning about the process to develop a profile. We'll talk a little bit about that, although there is a video that somebody will put a link to that talks about the methodology behind it as well. Understanding what the barriers are for the community group. Yeah, we'll definitely be talking about that. And just general awareness of the community in the UK and in Birmingham. Yeah. Okay, so if we move on from that now, I'll just get started to talking about the community profiles themselves. So what are the community health profiles? They're desktop pieces of research which summarize the published evidence, grey literature, and population survey data. They provide a snapshot of the physical and mental health of a specific community, as well as the lifestyle, behavioural, and wider determinants of this. And each of the profiles look at the health inequalities throughout the life course, and information is presented in themes according to the key priority areas identified in the health and wellbeing strategy. Generally, the profiles want to move away from acronyms such as BAME and LGBTQ+, which homogenise communities together and often overlook some of the huge differences in health outcomes between population groups. And in addition to the profiles, there's also census infographics that are shorter and more accessible summaries. And you can find out more about the background of the profiles and how they were, like the methodology behind them, at the link to the video that someone put in the chat. So to get started on talking about the profiles, from the 2021 census, the most appropriate way to capture the South African population was through the country of birth. So that's a 190 category data set and this allowed information to be captured in a way that ethnicity and nationality didn't. Country of birth data was used for the multivariate data analysis as well, but this couldn't be accessed on a Birmingham level and was limited to England and Wales level for some variables. The census also provided some data on length of residence in the UK, ethnic group, and English language proficiency, which were quite useful for understanding the South African population, what it looked like in Birmingham, and some of the barriers that they might face. But there were some limitations with the data as well. So next slide, please, Ellie. So there's several limitations with the data on the South African population. Firstly, there's a limited understanding of the South African population within the UK generally, as the population isn't widely recorded within demographic data. And that's meant that there's a reliance on international data within the profile, generally speaking. But using the country of birth data as well within the profile is limited, as it only captures the experiences of first-generation migrants and doesn't explore the experiences of second or third-generation migrants or the differences between these. Furthermore, people from South Africa have a wide range of ethnicities, including white, black African, mixed, Asian, and other ethnicity. So it's not possible to use a single ethnic category as an approximate for the South African population, although a lot of the time they are included under white other. BCC demographic. So Birmingham City Council have kind of recognised that there's some barriers with collecting data for the South African population. So they've developed a demographic data collection tool and have suggested within this that the South African ethnic group is defined as its own category. So using this ethnic group as a separate category, as well as providing the option for people to write in their specific country of heritage as well. And that provides a clearer overview of the population and allows for specific breakdown by country of heritage in a way that's not going to exclude second and third generation migrants. Just in the data sets generally as well, it's also important to note that across all of the profiles, there's a limited understanding of intersectionality. So somebody's identity and their experiences won't just be linked to their South African identity. There's also their age, their gender, sexual orientation, faith. People might have disabilities as well, and all of those things can compound to impact people's health. So if we look at the demographics, can you just go back to the previous slide, please, Ellie? Cheers. If we look at the demographics of the population, the South African population in Birmingham is relatively small, and the 2021 census showed that there were 1,629 South African born residents living in Birmingham. However, the population size is likely an underestimate, as it only captures the first generation migrants. There were 217,180 South African born residents across England and Wales, and the United Nations data from 2020 showed that the UK was the most common destination for emigration from South Africa. Using the country of birth data for West Midlands, we can see that there was a larger proportion of the South African population aged between 20 and 44 compared to the West Midlands average. However, the age category for 25 to 44 is likely an overestimate, as that only accounts for first generation migrants, and second and third generation migrants are more likely to be from younger age groups. When we look at the religion of the South African population, 58% of South African born migrants in the UK were Christian and 30% had no religion. That compares to 46% and 37% respectively for England and Wales. For national identity, the population with only a South African identity declined from 59,000 in the 2011 census to 43,000 in 2021. And that's despite an increase in the overall population. This being lower than the overall population size is likely due to the integration of the South African population into British society and people choosing to identify with British or British South African identity more commonly. And around 86% of the South African born UK population are from the white ethnic group, and 5% are from the black ethnic group. And interestingly, that varies, or that differs significantly from the population within South Africa itself, where 80% of the population identify as Black African. So there's a massive difference there in the South African demographics within the UK and actually within South Africa. And yeah, finally, we can also see that 95% have English as a main language. So high English language proficiency within that group as well. Moving on to look at the geography. It can also be useful to understand the geographic distribution of the South African population in the UK and within Birmingham, as that can help to inform place-based community events or health interventions. So where people live might not be where the community engages though. So it's important to use a mixture of data and community intelligence as the best approach. That said, a useful tool for understanding the geography of the South African population is the 2021 census mapping tool. And if you've not used it before, I recommend it as a way to understand variables more visually, and that's for all community groups as well. The tool allows you to look at variables at a middle layer super output level, which is a sort of complicated way of saying an area containing approximately 2,000 to 6,000 people. But how specific the area you can view is determined by the data because of things like data protection and disclosure risk. But for the South African population, we can see that from the map that 0.1% of Birmingham's population are South African. And the middle super output areas with the largest South African born populations are Edgbaston North, Selly Oak, Edgbaston South, and University. And I've just noticed there's an error on the slide. It says South American, but it should say South African. So just apologize for that now. Before we talk about the inequalities of the South African community, we've got 2 Menti questions now. So we'll just move on to those. And again, I'll wait a couple of minutes just for people to respond to those. So the first question for anybody that can't see it is, how do you currently use health data to inform your work or decision making related to addressing health inequalities? And if anybody is struggling with the Menti, you can just answer the questions in the chat if you prefer. Just give it 10 more seconds and then move on to the next one. So the next question is, how confident do you feel in identifying the health needs of the South African population? So this is just to sort of gauge where you're at in terms of understanding the health inequalities. And then we'll do the same. Okay. So someone's put in the chat, not confident. Okay, we're at about a 2.5 out of. Yeah, no worries if the Menti isn't working for you, that's fine. As I say, I'll read out the questions and they're already in the chat as well, so you can respond to them in the chat. Okay, so we're on about a 2.5 now. So I'll go on to talking about the health inequalities themselves, and hopefully we can improve that. So for this section of the webinar, in nature of time, I'm only going to focus on one key piece of data from each of the sections of the report to show the sort of types of findings that are available. And where possible, the presentation is going to highlight the best quality data. So that's data that's using large scale studies or national databases. And the data presented on the slides doesn't necessarily reflect. Could somebody let? Yeah, sorry. The data presented on the slides doesn't necessarily reflect the biggest areas of importance in terms of health inequalities. It typically just shows the inequalities where data was the strongest throughout the report. And the slides aren't going to provide a comprehensive understanding of all of the health needs relating to the South African community. So it's more just a starting point for people to go away and conduct further research as well. And it's suggested that people in the webinar go away and read the full profile and any cited data for additional reading as well. With that said, I'm now going to talk about the getting the best start in life section. So when we look at total fertility rate, we can see that this was 1.79 for mothers born in South Africa living in the UK compared to 1.5 for UK born mothers. The total fertility rate is defined as the average number of live children that a group of women would bear if they experienced the age-specific fertility rates of the calendar year in question throughout their childbearing years. And I know that's an absolute mouthful, but it's just a complicated way of saying how many babies each mother would be expected to birth. So a total fertility rate of 4 would indicate an anticipated 4 children. So from that, generally, we can see that it's pretty similar between the South African population and the UK-born population. And ONS data by country of birth is for 2011 at the moment, as it wasn't available for 2021 at the time this profile was put together, but it will be updated going forwards. When we look at infant mortality rates, in South Africa, there were 26 deaths per 1,000 live births in 2021, and that's compared to 3.7 in England and Wales. So a significantly higher rate of infant mortality in South Africa. When we look at maternal mortality, the rate in South Africa was 127 per 100,000 people in 2020, compared to 10 per 100,000 people in the UK. So again, significantly higher maternal mortality rates. And some of the factors that contribute to that are HIV-related infections being reported as one of the leading causes of maternal mortality in South Africa. And that accounts for around 12% of all maternal deaths in South Africa. And other top leading causes include obstetric hemorrhage, which is excessive bleeding during pregnancy, and hypertensive disorders. According to the Department of Statistics in South Africa in 2020, most of the causes of maternal mortality in South Africa were also preventable. So, and the biggest challenge comes from things like late booking, with only 47% of women in South Africa attending antenatal care visits during the first trimester. But it is also important to recognise, and this kind of goes for a lot of the data in this profile because of some of the limitations, it's important to recognise that this might not apply to the South African population within the UK, and their experiences could be very different. And that in itself kind of highlights the need for more data at a UK level. With that said, it's important that we recognise that people migrating to the UK from South Africa might experience some of these inequalities around infant mortality, maternal mortality. So now if we move on to the mental health and wellbeing section. So there's no data on the mental health of South Africans in the UK. So we've had to look more broadly towards international data. On the mental state of the world mental wellbeing scale, the rate of those who reported they felt distressed or struggling increased from 29% in 2020 to 36% in 2021 within South Africa. And South Africa scored the joint lowest average in the mental health wellbeing scale of all 34 countries analysed, and that was tied with the UK, interestingly. The scale itself ranges from -100, that being distressed, to 200 being thriving. And there's a baseline of 50, which is sort of between enduring and managing. That's kind of how the scale worked. And it captures perceptions of 47 aspects of mental capability and functioning on a life impact scale. But just one caveat is that measures of mental well-being inherently reflect sort of an individual's sense of how their mental health is, rather than their actual ability to function within life and their absolute sort of mental capacity. So it's kind of a subjective thing. With that said, like, it was getting worse in South Africa from the scale. One of the barriers to general mental health in South Africa is the availability of services. So there's a lack of available mental health services. However, local data might show a different picture as well. And it's unclear how South Africans access UK mental health services via the NHS or other routes. Moving on to healthy and affordable food. Again, and this is going to be a common picture, when we look at healthy and affordable food, there is no data on the South African population within the UK, so there's a gap that needs to be filled there. But the Global Nutrition Report from 2023 is an overview of national dietary intakes of key food or nutrients of adults aged over 20. And the report showed that there was high consumption of red meat in South Africa, with people on average eating 1,061% of their daily target. So like 11 times the daily recommendations. The average intake being 149 grams and the recommended being 14 grams. There was also low consumption of fruit, with people consuming 16% of the daily target. The average intake being 33 grams and the recommended being 200 grams. There was also low consumption of vegetables at 44% of the daily target. Average intake being 132 grams and the recommended being 300 grams. Yeah, I'm just about to talk about the obesity rate. So, and there was also reported low consumption of legumes. So in 2023, data from the World Obesity Federation in South Africa showed that 20% of men and 27% of women were overweight, and 11% of men and 41% of women were obese. That compares to 41% of men and 31% of women being overweight in the UK, and 20% of men and 20% of women being obese within the UK. In this study, obesity was measured as BMI score of 30 plus, and overweight was measured as BMI of 25 to 29.9. But it's important to note with using BMI as a measure that there are at the moment a lot of debates around the use of it to measure things like obesity and being overweight. And sometimes it's recommended that what BMI score is used to determine obesity should be adjusted for different demographics as well. So you kind of got to take some of those. Yeah, exactly. You've got to take some of those data, not with a pinch of salt, but there's some considerations there as well. And I think those will be explored a little bit in more detail within the profile itself. Moving on to active at every age and ability. So when we look at physical inactivity by age and gender, physical inactivity was lower for men over 18 in South Africa at 29% than it was in the UK, which was 32%. However, it was higher for women over 18 in South Africa at 47% compared to 40% in the UK. Similarly, when you look at people over the age of 70, physical inactivity was lower for men in South Africa at 41% compared to the UK, which was 47%, but higher for women in South Africa at 64% compared to 56% in the UK. So overall, South African men were more active than UK men, and South African women were less active than UK women. However, the physical activity recommendations did differ between the two countries. So in South Africa, recommendations were for adults to undertake 30 minutes of moderate intensity physical activity every day of the week. So that would be 210 minutes in total. Whereas in the UK, recommendations were for 150 minutes per week of moderate physical activity. So from that, we can kind of assume that South Africans are generally more physically active. And a study in South Africa of 381 participants had identified contributors to sedentary behaviour among adolescents as being things like poor maternal education, barriers relating to puberty, and socio-economic status. Now, if we move on to living, working, and learning well. So this is an area where we actually do have a little bit more data on the UK from the 2021 census, so that's quite useful. And in the 2021 census, within the employment area, it shows there are high levels of economic activity among the South African population. So that's 78% compared to 61% for the England and Wales average. There's also a high percentage in managers. So when we look at the types of jobs that people were in, there's a high percentage of people who were managers, directors, and senior officials. That's 18% compared to 13% for the England and Wales average. And also a high percentage of people in professional occupations. That's 31% compared to 20% for the England and Wales average. Professional occupations in the census include things like teaching, other education professionals, IT professionals, nursing, and midwifery. When we look at the housing data, we see that in the 2021 census, 38% of South African-born people lived in owned properties, compared to 36% for England and Wales. So that's a very similar level there. However, 37% of South African people lived in socially rented properties, compared to 8.3% in England and Wales. So it's significantly higher for social renting. And within the profile itself, I think there's some exploration of how that might relate to certain like environmental health inequalities as well. When we look at general health, 55% described their health as very good, compared to 48% for the England and Wales average. But it should be noted that this metric is self-rated, and it will depend on an individual and the community's perceptions of what good health is as well. Finally, moving on to the protect and detect section. And this is one where there's more significant health inequalities, I would say. South Africa has the highest HIV prevalence in the world, with approximately 13%. That's 7.7 million people living with HIV in South Africa. And South Africa represents 18% of global HIV concerns. And that compares to 0.16%, so 106,000 people in the UK population living with HIV. So there's a significant difference between the two countries there. UNAIDS has a target called the 95-95-95 target. And this means that they want 95% of all people living with HIV to know their HIV status, 95% of all diagnosed people with HIV to be receiving antiretroviral therapy, and 95% of people receiving antiretroviral therapy to be virally suppressed. That relates to another goal of people being undetectable, meaning that they're also untransmittable as well. Migrants from countries with high prevalence and low knowledge of their HIV status are a priority within the UK health services and should be encouraged to discuss their healthcare needs on arrival. And according to the National AIDS Trust, migrant populations in the UK are disproportionately affected by HIV. So due to this high HIV prevalence in South Africa, for South Africans in the UK, it's important to offer and recommend HIV testing to all children and adults according to the UK national testing guidelines. I just saw a question in the chat as well, so just give me a sec to find that. No, at the moment we don't have data on how many South Africans born in the UK have HIV, and that is a major gap that needs to be filled, I would say, given that South Africa has the highest prevalence of HIV in the world. Monitoring the HIV prevalence of people with South African heritage that are born in the UK is really important, particularly when you factor in things like transmission from mother to baby as well during pregnancy. It's a massive consideration, and like the data needs to be collected. Finally, moving on to aging and dying well. There's very limited data with the aging and dying well section of the report. So, but looking at international data, the life expectancy at birth in South Africa is 59.3 years for males and 64.6 for females in 2021. And that compares to 79 years and for males and 82.9 for females in the UK. Two of the largest contributors for decreased life expectancy in South Africa are HIV and TB, so tuberculosis. And generally, communicable diseases are larger contributors to mortality in South Africa. So that highlights the importance of providing information, testing, and early intervention for recent migrants from South Africa as well. Now I'm just going to conclude on some of the health inequalities. So moving on to the next slide. So there's lots of other health inequalities covered within the profile, and I'd encourage everyone to go away and read the profile for more details on that. But just some of the other major ones that weren't included, looking at protect and detect and getting the best start in life. When we look at dental decay in children, a systematic review for South Africa found that 52% of 5-year-olds in South Africa were identified as having early childhood cavities, and that's compared to 23% in England. So for people migrating from South Africa, that's something to be aware of. So like early intervention with children around dental health. Looking at violence and domestic violence, worldwide, 27% of women and girls age 15 and older have experienced physical or sexual violence from partners or family. But in South Africa, that's between 33% and 50% who have experienced that. And the data does vary on that. But again, that's something to be aware of for people migrating from South Africa. And then finally, when we look at air pollution, and environmental health. 15% of South African-born population in the UK resided in the top 15 most polluted MSOAs, so the middle super output area levels in Birmingham within 21. And that's 15% compared with 5.4% of the white British population. So generally like 3 times the amount of the South African population are living in highly polluted areas. And that itself relates to much higher inequalities in terms of environmental health. Overall, sorry, one second, just reading the chat. So are there plans to record the second gen migrants' health to compare? This will, be useful to see how UK health promotion, etc. impacts. On our end, no, there aren't plans to record. However, within public health, we've developed a demographic data collection tool that specifically identifies different South African ethnicities. And we're hoping that if that gets adopted by other services, it'll make the South African population more visible within the data. So at the moment, they're often come under like white other, or they're aggregated with other communities. So keeping them separate will make it easier to understand health inequalities that they experience over time. And that would go for first generation South African migrants, as well as second generation migrants as well. But specifically, our team aren't going to be collecting data on the health inequalities they experience. Overall, the profile itself provides an evidence summary of the inequalities that can be used to develop different solutions. However, it's not an exhaustive document that's going to map the experiences of all South African people in the UK. And the profile has highlighted significant gaps in the UK data on the South African population. So one of the major recommendations from it is for different organisations to go away and improve that data. It's also important to consider the intersectionality and the influence of other aspects of people's identity when making decisions regarding services and resources in healthcare. Particularly with the South African population, it's important to understand the health inequalities based on ethnicity. So the difference between experiences of white South Africans and black South Africans living in the UK, and how those inequalities within South Africa itself might transfer over for different migrants. We're just going to have another quick check-in on the Menti again. So the next question is, how confident do you feel in identifying the health needs of the South African population now? And I think with this profile particularly, it might not improve understanding of health inequalities that much, because one of the biggest findings from the research that we've done is that there is a massive gap in the data. So it's more of a profile that's advocating for change and the gathering of more data. Yeah, so I'm a bit more confident, but lots more questions. I think that's a fair assessment with this profile, to be honest. If anything, it highlights the importance of getting more data, because there are potential issues, particularly around some of the areas like communicable diseases. It highlights the importance there. So we're on a 3.3, which is up from 2.5, so I'm happy with that. So we're quickly going to move on to the last section, where I'll discuss some of the next steps in how the profiles can be used. I've kind of touched on some of this already. All of the profiles are currently in their draft version, and can be edited. So we'd encourage everybody in the webinar to read the profile, and we'd appreciate your feedback on those as well. So for example, if you feel there's any inappropriate language used or an important report or data set hasn't been included, then please do let us know. And all of the profiles will follow the same templates for the sections. If you feel there's like a section that should be added to this profile for the particular community, please do let us know. Similarly, if there's a health need or a like key sub-community that's identified as an area of importance, then, and that hasn't been included, then you can let us know via email as well. And somebody will put so Rupi's just put our email in the chat as well. We're also happy to set up feedback sessions. So like if you don't want to email us and you'd rather talk about it as well, we can set up one-to-one discussions over Teams or Zoom or something like that. And if your organization works specifically with South Africans, the South African community, or you offer a specific health service for that population, then we can add your contact details to the report as well in the appendix, just to make it easier for people to reach out to you as well. Now just moving on to some of the different ways to use the profile. In terms of how we want the profile to be used, we encourage everyone to go away and read them just to build their knowledge and their understanding of the health inequalities of the community, but also to share it widely with colleagues, wider organisations, partner organisations and networks to encourage them to do the same. And the profile can also be used as a tool when engaging directly with that community to support them in advocating for change. And we want people to use the data and the evidence within it to inform and support new health interventions, new policies, new service proposals, and particularly with this profile to justify further primary data collection as well. We're also keen for the profiles to provide a rationale for things like funding bids to get more money into that space and to deliver specific projects with that community. But that said, the profiles only offer headline data within each section, and the breadth of the information covered means that additional sources of community intelligence should be used as well, particularly like direct consultations with the community. We've got a few more Menti questions now, so we'll just move on to those. So the first one is, how do you envision incorporating the findings and insights from today's discussion into your work or organisation? Rupi, could you just copy those questions back into the chat for anybody that joined late as well and wants to answer in the chat instead? But yeah, the first question is, how do you, so somebody's responded. Yeah, so to support creating profiles in your area. Okay. That would be useful. And I mean, I think there'll be a lot of, particularly with this community, because a lot of UK wide data and international data has been used, it'll transfer to other areas within the UK as well for this community. But there is definitely a need for more local data. So if we move on to the next question, in what ways do you hope to see healthcare services become more inclusive and supportive of that community? I'll just wait a second. Yeah, so just generally increasing their understanding of that community, some of their the different inequalities they experience and how they can tailor their approach to that. Yeah, adapting the work that they do, the different methods they use for outreach, that to become more appropriate to that population as well. So finally, what other intelligence? Oh, there's another one. Yeah, education regarding the inequalities, first generation and beyond. So the next question, what other intelligence would be helpful to inform your work or improve your practice? So I'm not sure what areas different people work in, but what sort of data would be useful for you in your work around this community? Yeah, so things like case studies, qualitative data from the communities themselves. So just things that provide a bit more of a contextualized understanding of that community's experiences. I think that is just as important as the quantitative data and the gaps there as well. Just wait another 10 seconds. Okay, so data for the local community and linking in with other frontline organizations. Yeah, exactly. That's massive. So it's not just healthcare organizations that come into contact with this community. It's thinking about how third sector, other health and social care organizations can work together more effectively to understand the experiences of this community and generally address the health inequalities they experience. So some of the inequalities we spoke about were around like housing, air pollution, stuff like that. So it's important to think about how wider services can engage as well. So, okay, we'll move on now just to do some of the closing bits. So we've got a range of other webinars on our profiles that can be found on the Healthy Brum YouTube channel. We've done most of them already, and you'll be able to find them at the links that have been put in the chat already. I would say some of the other profiles have a lot more high quality data and more significant health inequalities as well. So I definitely encourage people to go away and look at those. We also have far more profiles and webinars beyond the ones on screen as well. These are just from our most recent round of profiles. But yeah, I'd encourage everybody to go away and look at those. And we've got 2 more coming up in the next week or so on the Arab community and our student population in Birmingham as well. So now moving on quickly, we're also, as part of our wider community health profile work, we're conducting an evaluation of the profiles through the University of Birmingham. So you can provide your feedback on this as well, in terms of how you've used the profiles, how you'd like them to be used, that sort of thing. Somebody will put the link in the chat on how to provide your feedback on that. So what are we trying to understand through that evaluation? We want to understand the role that the community health profiles play in different organizations and in different stakeholders' decision making. We also want to find out about the confidence that different organizations and stakeholders have in using the community health profiles, how accessible and suitable they are, including different things like our infographics. Do they need to be translated into more languages, that sort of thing, and just generally assessing the impact of the profiles and the subsequent community engagement partners that we will have for some of the other communities as well. And if you don't want to fill out the evaluation form, you can also just drop us an email at our team email as well. So that's the end of the presentation, and now we've got a bit of time for a Q&A as well, if anybody wants to ask any questions. And I'll also turn off the recording shortly, just in case anybody wants to ask questions off the recording as well. So I understand some people might not want to ask questions on the recording. So yeah, I'll wait like 30 seconds and then turn the recording off. Okay, it doesn't look like there's any questions, so I'm just going to stop the recording, and then if there's any other questions once the recording's stopped, do let me know.